Well, thank you, and good morning, everybody. And it's a real pleasure to be here. It's my first time at this meeting, and of course, first time as chair of the General Medical Council. And I always welcome an invitation which is left a bit open to interpretation, and certainly having doctors and regulation as a brief is about as open as it can possibly be. So today, I'd like to take a step back and think about how we, as a regulator, are working with you as doctors to improve your practice and in parallel the environments in which you're working. So my first thought is that we should acknowledge that 2018 was a challenging year for the General Medical Council, and in particular for our relationship with you. There's no doubt that your confidence was damaged, and I know that I need to rebuild it, and I've made that my first priority coming into my role. My starting point really has been to understand exactly what the GMC is already doing, and it's become clear to me that we are already on a journey from being a reactive regulator towards being a focused as a regulator that looks at anticipating the risks to patients and works with doctors and indeed the whole system to be more proactive and in a more collaborative way. To achieve that vision, we must develop further into a standard setter focused on making patients safer by promoting well-trained and well-supported doctors who are working in supporting environments. So my aim is simple. I want us as a regulator to support you in your goal of being proud to be a physician. Today, I want to highlight what the GMC is already offering in 4 key areas: our standards and ethical guidance, reform to our fitness to practice processes, and promoting clinical leadership, and then supporting you in the front line. And I hope that you will see the progress that we've made, but to improve further, we need you as individual doctors and as a Royal College to work with us. Fundamentally, the General Medical Council is a creature of statute, and our role and how we carry that out is shaped, sometimes in very minute detail, by a law which is 36 years old. There is a lot we're already doing to support those we regulate, but we can only really deliver transformative change if those laws that govern how we work are updated. And we've been asking the government and Parliament for some years to do that, but we now need you to work with us to secure those changes. So today, I'd like to start by focusing on our standards and guidance. Doctors make difficult ethical decisions. Some of these have legal implications. The interaction between the 2 sets of values and rules is complicated. It can be difficult to know where one starts and the other begins. We want to act as your guide in making these decisions. The GMC isn't there to determine what is legal and what is not. Like everybody else, it must follow the law of the land and adapt as that evolves. All of the guidance we develop, therefore, has the law as its starting point. But we do try to define what the law means in the context of medical practice and what wider society might expect of you. That is why good medical practice is all about that, and we expect all doctors to be familiar with good medical practice. I've been struck by the level of support the GP actually offers doctors and what that range of support has grown and how it's grown in recent years. Sometimes that's been in response to doctors' needs, or patients' needs, or sometimes in response to a new law, a public inquiry, or an independent report. Our role is to help you practice in line with the ethical norms and the UK laws in many complex areas. And we are here to support you in adapting to the changing needs and expectations of the people with whom we work. There's now guidance on a range of topics such as child protection, social media, remote prescribing, duty of candour, and cosmetic practice. We are helping you to make decisions, and we're doing that in consultation with you and others. Our consultation on the consent guidance alone has involved hundreds of conversations. As well as new publications, we revise existing guidance, and we ensure that it is current and reflects situations in which doctors find themselves. We published revised confidentiality guidelines in 2016, and as I mentioned, we're currently updating the guidance on consent. To facilitate your access to the increasing volume of guidance and other resources, we've completely revamped our website, and it's much more user-friendly. Each piece of guidance is briefly summarized so you can see at a glance what it covers. We've also created supporting materials such as decision tools, checklists, and case studies, and this will help you work through challenging issues. There is a My GMP app that gives you access to all the GMC guidance on your mobile device, and many of you are already using our inquiry service desk, seeking further clarity on guidance. But of course, we can only get value out of the service if you use it, so please use it, and please provide us by giving us some feedback on how we're doing and what you think could be improved. So I invite you all to download the app, but perhaps after I finish speaking. However helpful these standards and ethics are, it is equally important that we deliver our fitness to practice processes well. Being referred to the GMC is an incredibly stressful experience for any doctor, and the investigation process takes longer than anyone would like. Whilst that is partly a function of the law as it stands, in the absence of legislative reform, we're really working hard to make the process fairer, faster, and more focused. A system of provisional inquiries is one way that we've done that, and we now filter many more of the complaints we receive about doctors. Where appropriate, we can make a provisional inquiry into a case and complete that in 63 days, which, although it's a long time, is very much better than the minimum 6-month period of a full investigation. In 2017, the provisional inquiries prevented about 400 doctors from undergoing full investigations. And so we are now extending those provisional inquiries to cover single clinical incidents. We're getting faster at assessing whether the single clinical incident points towards an ongoing risk to patients, and in a recent pilot, which took a couple of years, that approach ensured that about 200 referrals did not progress into the full investigative stage. Promoting clinical leadership is a particular passion of mine, and some of you will know that I was chair of the Faculty of Medical Leadership and Management before I took on this role. Care is always going to be anchored in the foundation stones of knowledge, skills, and compassion, but change is the way that the profession moves forward, and that change has to be led. We see major challenges for the system, including the sheer number of patients that we treat, and we heard in the last talk about the increasing number of outpatients. We know that in the last 15 years, the number of attendances at major accident and emergencies has increased by about 18%, up to about 15 million a year. And these increases have been sharpest in the last few years. As you will all well know, you feel those increases, and that produces challenges for you maintaining the quality of care, both at an organisational and at an individual level. I firmly believe that effective clinical leadership is at the heart of responding to this, and that takes training, commitment, and time. The leaders themselves need to be supported to lead their teams efficiently and effectively. The emerging evidence is that good clinical leadership is not just good for patients, but is also good for staff. You have been telling us about the pressures you feel in our feedback surveys. If we are to support you in your aim of being proud to be a physician, then we must support your efforts to be good clinical leaders. We also know that successive high-profile inquiries into incidents where patients have suffered have shown a constant theme of there being a lack of effective clinical leadership. And so the GMC, which has oversight of medical education and training through the standards that we set, can use its levers to proactively ensure clinical leadership skills are acquired. Leadership skills have become a specific outcome of the medical schools, and it also is a compulsory element of foundation programme for doctors in training. We've also embedded the need for such skills to be a requirement of postgraduate curricula that are set by the Royal College of Physicians and other colleges. Today, we are using all our regulatory tools to ensure that leadership skills are acquired as a doctor moves from the undergraduate to the specialist. Alongside supporting leaders, the GMC recognises the need for us to support doctors in the front line and to give help to those that are employing them to be supportive. That need has increased, and we've seen the system has increasingly come under pressure, and we know that we need to do more. We've developed new approaches and resources in response. We have a regional liaison service that became fully operational in 2013, and that has worked with about 16,500 doctors, 9,000 medical students, and 1,000 patients in its first year, providing guidance on our core functions, fitness to practice, providing guidance and about revalidation and ethical standards. Now each regional advisor is an expert in the respective health economy. They prioritise support for doctors based on needs, and they share intelligence with other regulators to manage emerging concerns locally. We are now providing sophisticated improvement interventions such as Duties of a Doctor's programme, which looks at ethics, and Welcome to UK Practice, which helps doctors new to the UK adapt to new environments in which they find themselves. 5 years on from the launch of the Regional Liaison Service, we've now worked with about 46,000 frontline doctors every year, and about 75% of those doctors are saying that the information we give will change their practice. But the support we provide is more than just training sessions. For example, a gastroenterology department, there were some concerns where severe rota gaps were raised by some of the SAS doctors working in that service. Our local liaison officer met with the trainees and the Guardian for Safer Working, and then coordinated submissions of a campaign of exception reports, which ultimately led to better staffing arrangements. In another example, the regional advisor met with trainees concerned about persistent and unresolved rota design issues. That advisor then worked with the NHS England and HEE on their behalf, and those institutions intervened to give direct support to the trust management. So these interventions work. The GMC is actually out there on the front line delivering support to doctors and doctors in training every day. And we're making a measurable difference in those environments. So when I look at the RCP's strategic priorities, I was struck by the first one, which is that you want to promote a sustainable workforce. As a regulator, as your regulator, we share that goal. In the past 3 months, we've worked very closely with Baroness Harding's Workforce Implementation Group, which is supporting the NHS long-term plan. Like you, we want to make the UK a place that is attractive for people to continue to work and train in. We also want to see that people are able to come to the UK and the services are more accessible. And so we're working to see if our regulations to enable greater flexibility on the path to CCT can be enabled. We also want to make sure that we can facilitate physicians' associates working with our teams and promote a positive and reflective learning culture. Secondly, we're developing a more sophisticated understanding of individual systems factors that play into the fitness to practice. We know that we have to understand the underlying factors that often lie behind clinical incidents. We therefore are delivering clinical human factors training to all the staff at the General Medical Council involved in fitness to practice investigations so that they can properly assess the wider issues, and that will be part of the assessment they make when clinical incidents are referred to us, and they will consider those factors when they're taking decisions about how we will proceed. Thirdly, we're going to be working with you and other colleges promoting a new professional behaviours and patient safety programme that will help to tackle the broader issues of bullying and undermining behaviour. The RCP involvement in that has really been critical so far, and I'd like to thank you for that today. The evidence shows us that these types of undermining behaviours undermine the safe care of patients and contribute to difficult working environments for all health professionals. In one study, we saw that 14% of doctors and nurses reported being aware of specific adverse events related to an episode of disruptive behaviour from colleagues. So if this level of harm was being caused as a result of a drug error, you can imagine how much focus, resource and energy would already have been put in education and training to improve that system. So we share the RCP goals for a more sustainable workforce, and we are working with you to try and achieve that. But we want to go further, and our ability to do this is shaped by the legislation that governs us, and we need to have that reformed. Firstly, we need to streamline international registration. The CSER process is long and burdensome, and it can take nearly a year to compile all the data, and it costs about £1,500. So not surprisingly, in the last 5 years, only about 685 doctors a year have applied for the route into this system of specialist or GP registration. So we definitely need to get that more flexible. Secondly, introducing regulation for medical associate professionals. And of course, the RCP has played a key part in making the case for regulation on physicians' associates. The government has now committed to regulating them, but have not said who should take on that role. And we simply need a decision on that to be taken, and we need the necessary legislation to be passed. And thirdly, as I touched on earlier, we really need fundamental reform in the way fitness to practice works. In 2017, only 18% of the complaints we received about doctors actually went on to become investigations. But the law as it stands means that we have to look in detail at all 8,500 of these complaints. Is this really the best way of using our time, a very large chunk of the registration fees you pay us, and does it protect patients? Well, the evidence says no. Far more complaints should be dealt with locally, and only the most serious matters need to be brought to the General Medical Council. The law needs to be changed on how to allow that to happen. If the GMC is to change the way we work, promote a supportive environment for those we regulate, and a sustainable medical workforce, then these reforms are essential. And I'm calling on you and the RCP as a whole today to work with us and to make the case to government for a swift delivery of these reforms. We are clear that the best way to protect patients lies in having well-trained, well-supported doctors working in supportive environments. Change takes time, commitment, and in our case, legislative change. We have far more to do, and I know that working with you all will make that possible. So on the screen now, you have our contact details, and I invite you to feedback to us by letting us know what we can do more to help you. Thank you for listening.